Hi, I'm Michael Graham with Inside Sources. Thank you so much for joining us for the Common Sense Public Health Roundtable. You know, it's funny, this idea came from two things. The first one was I was in a conversation with someone about how much I hate daylight savings time, and what I really hate is changing the clocks. And I was quoting him data that shows that every year that we change the clocks, there are a few hundred heart attacks that wouldn't have happened otherwise, a few hundred other car accidents. I said, you know, if you just stop changing the clocks, there's a couple hundred people that would be alive right now. And it kind of evolved into this, you know, while the debate goes on about the right way to micro or macro manage America's healthcare system, where we have vast debates about Medicaid and Medicare, et cetera, right now there are public health experts who know things that you could do that would take minimal cost, but would have a significant impact. I thought, oh, what a great idea. So I happen to know three very smart people who have those ideas, Dr. Richard Williams and Dr. Brian Miller. And I don't know if you are a doctor or not, Clive, but unspoiled by a PhD. And so I've asked them to join us, and we're going to have a conversation, each one for 15, 20 minutes, and then we're going to open up to questions for our people on the stream. Thank you, journalists, think types, whoever joined us here today, and from the folks here in the room at the National Press Club. So Dr. Richard Williams, I give you the magic wand to do that one. Remember the one weird trick ads when the internet first got big? One weird trick, how to burn fat. One weird trick, how to grow hair. What is your one weird trick? That one thing that's relatively simple and easy, but would have a major public health impact.
Well, I think the number one thing I would do is I would replace the FDA's human food programs, and I would replace it with something that would give both consumers and producers better choice, and that would address food safety and nutrition problems that are plaguing us. So as I ended my tenure at FDA back in 2007, and I'd been there almost 30 years, I was compelled to write a book because we hadn't really made a whole heck of a lot of progress. And I think today the biggest myth is that we treat FDA like it's a revered institution, when in fact, it's more like an old company that's selling outdated products. And some people are beginning to understand that there's a problem. And the most recent problem is the one that people are focusing on, the infant formula problem. But the infant formula problem is just a one-time occurrence, really. And FDA, unfortunately, is probably partially responsible for the infant formula problem. They have always written letters to people who wanted to come into the market and say, please don't come into the market. We don't want to have to regulate more people. Then, unfortunately, when they did inspect a violative plant, a plant that was filthy, they sort of missed that. And they were late figuring out that we needed to increase the supply of infant formula. But this is not the biggest problem. The biggest problem are the systemic problems with food safety and nutrition. And FDA is under fire right now. I mean, they must feel like Kodak did back in 1968. Kodak had been around for 80 years. New technologies were coming around. Kodak couldn't respond fast enough. FDA is 117 years old. And things are going on that they can't keep up with. So because they're under fire, what did they do? Well, they went and hired the Reagan-Udall Association, which is composed of a lot of friends and ex-FDAers, and they paid for them. And what they came up with is, what should we do about FDA? Well, it's four things. One, let's give FDA more visibility and prominence in the human foods program. Let's give them more money. Let's give them more authority, and let's reorganize the human foods program so we'll have a clear chain of command. On the visibility and on the reorganization, I thought, did somebody just mention deck chairs in the Titanic? I'm not sure what's going on here. FDA doesn't need more money. They've continually gotten more money throughout their existence for foods. They certainly don't need more authority. And in terms of reorganization, they've been reorganized lots of times. So to see that it's not working, just look at what goes on every single year. And nobody seems to pay attention to this. Every year, FDA goes to Congress and says, here's our budget justification. We need more money. And every year they make the same claims, and their claims come from the Centers for Disease Control. And every year, and this has been going on for decades, it's the exact same claims. 48 million people are getting sick every year from foodborne disease. 128,000 are hospitalized and 3,000 die. Nobody ever asks, well, wait a minute, you've been saying the same thing every year and we keep giving you more money, but nothing's happening. And they said, well, you know, they do inspect firms and they write regulations, and that's what they do. They have a whole staff dedicated to writing regulations which tell firms what to do every single day. And then they go out and inspect about every 6 years, but nothing ever changes. And if I'm a food company and I look at these regulations that I know aren't doing anything, they have to feel like Sisyphus. Every day we're rolling this compliance boulder up the hill, and every night it comes back down and we got to start complying with new regulations. So let me give you some examples in food safety on how this isn't working. Back in 2010, FDA, some former FDAers and others, got Congress to pass a law that said every firm has to comply with a process management tool called HACCP. Now, this is a tool that was developed back in the 60s. The U.S. Army in Pillsbury developed it. So those little toothpaste tubes, of food that the Apollo astronauts had to eat, they wanted to make sure that the astronauts wouldn't get sick. Well, the food industry started using it back in the early 70s. And then in the 90s, FDA tried to impose it on the seafood industry. It didn't work. So they've tried other things. So the other thing that happened after the seafood industry is we had a problem with fruit juices. What happened was apples would fall from trees. They'd roll around in deer poop. They'd get contaminated. You'd wash the apples. Not all of it would get off. You press the apples into making raw apple juice, and the next thing you know, it was contaminated and kids were getting sick. But FDA wanted to regulate oranges as well. Now, oranges are different, right? They have a real thick skin, and oranges don't tend to fall as much. But FDA wanted to regulate oranges. So what did they do? They took the oranges and they dunked them in water, purple water, and they held them underwater for hours. And then afterward, they cut the oranges, took pictures of the slides of the oranges, and held a big meeting. They invited the microbiologists from all of these orange-producing states over. And if you looked at it very carefully, you could see tiny purple micro cracks where the purple dyed water had somehow made it into the orange. And the solution that they found was we have now proven that rainwater can contaminate oranges on trees. Microbiologists started screaming. And then finally, more recently now, FDA has discovered that groundwater can be a problem from rain or from springs. It can be perhaps controlling pathogens. So they went around lots of rulemaking and they held hearings and they did everything and they couldn't come up with a solution, except here's what they did. They turned to the farmers and said, well, it's your problem. You got to fix it. So like Captain Picard on the USS Enterprise, they said, make it so. So FDA doesn't have any ideas of their own. They're out of ideas. And unfortunately, we all pay for this. Taxes to pay for FDA salaries, and then we pay for it in higher food prices, and then obviously in illness and death. This is the smallest problem with the FDA foods program. Nutrition is a lot bigger. Go to your local mall. You can see it, okay? So right now, 3/4 of us are overweight or obese. About 4 out of 10 people are obese in this country. By the end of the decade, that's expected to be 50%, 5 out of 10 people. FDA's role in this is part of a bigger government program. Their role is food labeling. Food labeling has now been with us for 30 years. No one knows how to use the food labels yet. So what has FDA done? Well, recently, again, they're writing those regulations every day. They increased the font sizes on some of the items in there. Oh, and they updated the mysterious daily values. In case you don't know what daily values are, don't worry about it. No one does. But they're the recommended amounts of nutrients you should have if you eat exactly a 2,000 calorie diet. If you don't, you got to do some pretty severe math to figure out what your recommended amounts are. And it's worse than that. Obviously, that's the recommended amount, for certain people. But if you want to know what your recommended amount is, you got to know something about your own genetics, your health status, how much you exercise, how much stress you're under, your age, your sex, tons of information. Well, FDA started putting those labels on way back in 1973. And the commissioner said, you know what, I'm looking at these labels and I think we got to study these before we put them on more foods. We didn't. In the 1990s, we didn't study them. We put on all foods, and that's where we're at right now. So this is a huge problem. Our nutrition problems are obviously going in the wrong direction, giving us diabetes. Half of us now are diabetic or pre-diabetic. Heart disease and cancer are going up. Just to put it in context, in 2020, COVID killed 350,000 people in this country. Poor nutrition killed 500,000. In addition to that, they're using a lot of old science. We're still using animal models from the early 60s where we dose animals 100 to 1,000 times more than what we would eat, and then we try to make some conclusions about that. So we're using old science. So now let me get around to answering Michael's question. What should we do? Well, in fact, there is one agency in the government that really comes up with great ideas, and it's in the Department of Defense of all places. And you've probably heard of it. It's called DARPA. It's the Defense Advanced Projects Research Agency. And they operate on something they call the Heilmeyer Catechism. It says generating big rewards requires taking big risk. And so my solution is when we replace the FDA, we replace it with two parts. And one of them would be a DARPA-like organization that would come up with new ideas. And in fact, there are new ideas coming up all around the world. We're just not using them. What's the key to DARPA that makes it different from the rest of FDA and other organizations? One, you have to take the bureaucracy out completely. No bureaucracy. Eliminate the complex procedures. Eliminate the rules. Take out the lifers who say, well, we've always done things this way, and that's the way we're going to do it now. It's a flat organization. They have one director. He only serves from 3 to 8 years, and then they're gone. Excuse me. And under them, in this flat organization, it's program managers or project managers. And what these are people from everywhere. They have out-of-the-box ideas, and they come in there to see if they can make them work. Unlike other labs, they're given a set amount of money, perhaps in different tranches, but it's a set amount of money, and they have a set time, usually 3 to 5 years. When the money is out and the time is out, the project's over. If they haven't succeeded by then, it's done. I'm sure all of you know laboratories that go on for decades and decades and decades, not these guys. So what they do is they come out, they try to create a prototype. And if the prototype works, then it will be picked up in DOD by the Army, the Navy, the Air Force, or so forth. Here it would be picked up by firms that might be able to use it. Let me give you some examples of how great DARPA is. They've created precision weapons, stealth technology, where not just planes, but whole ships now can avoid radar. I mean, this is amazing stuff. They created the digital protocols that gave us birth to the internet. Automatic voice recognition. All this came out of DARPA. GPS, like you use in your car and on your phone. All that came out of DARPA. That is a very short list as part of a longer list. DARPA doesn't have labs of their own, and they don't have requirements. So in DoD, the other labs would say, oh, we need a bomb delivery system. It has to deliver bombs from this height, at this speed of the plane, and it has to be a certain amount of precision. They don't have any of that. You just come in with your idea and you try to make it work. Other agencies have tried to copy DARPA. It's failed because they haven't taken the bureaucracy out of it. Usually there's too much bureaucracy and they have too much top down. So what can we do in food safety? Well, just some ideas that are out there now that we could use. There are foods grown in labs right now, not farms, which are pathogen swamps, labs using precision fermentation. Using that, you can make any kind of food you can imagine. You already have seen one, the Impossible Burger. Foods grown in vertical labs. So you can grow fruits and vegetables right in cities with vertical labs. Fantastic. Foods made in 3D printers. That's coming. I think one day we'll see a food 3D printer in just about every kitchen. We're seeing robots now in plants and restaurants. Robots, incidentally, don't have diseases that can get into your food. Smart packaging that would alert the consumers that this food is contaminated. Don't eat it. Trace back technologies, where now if something goes wrong, we can trace back things within about a couple weeks. This will be in a couple of seconds. So the neat thing about this is, under a DARPA-like organization, these would be public goods, meaning anybody could use them, okay? Any plant that needed to could use them. You don't need a regulation. If it works, you could use it. For nutrition, there's a lot of really neat stuff going on in nutrition. Forget food labels for a minute. We're talking about wearable or implantable devices that would tell you what to eat, when to eat, how much to eat, and it would be based on your own personal characteristics. They're just right now starting, but these things will be fantastic, and we can get beyond food labels. So I think the other part of the organization, you have to keep parts of FDA that are necessary. You need the police organization, all right? There are always companies that are going to try to cut costs or take shortcuts. You're going to need that. But we also need to go back and start again. We need to take all the FDA regulations, and we would need a small organization to start this off, to look at all of them and say, is this still needed? Is this working? I mean, just to give you an example, why do we have the 1938 Food Standards Law still in operation? This is a law that says, like Mother used to make. So we have half of our foods that have recipe requirements like Mother used to make. How many mothers are making foods from scratch these days? As far as I know, it's not a lot, because you don't have to anymore. And so but right now they're spending on time. Should almond milk be called milk? They spent a couple years trying to figure that out. It's time to start again. So this new organization would do three things, I think. It would generate new science to replace some of the old science we're using, like animal testing. It would create new technologies that would give consumers better choices on what to eat and how to eat safe foods. It would give producers better technology to make our foods safer. And it would use decision science more and more widely. So I just want to finish by saying this. The alternative, which is reinforcing FDA's status quo, It's not only unacceptable, it's dangerous. And that's it.
Okay, before we get to Dr. Miller for the American Enterprise Institute, I have a couple of questions for you. First of all, obviously almond milk is not milk. So we got that worked out, right? So we're all in agreement. Clearly not milk. It didn't come out of a mammal. It ain't milk. So
Right.
I'm glad it's there. There's your 2 years and $5 million. Second thing is, what are some other countries doing that you go, that's smart? Why don't we do this with our food that they're doing? Are there any examples come to mind?
Well, one of the things that Europe does, old Europe, they're actually doing better on regulations in general. So they actually are looking at, for example, red tape, all of the paperwork that goes. So for an example, FDA has a requirement that says if you're making what's called a low acid canned food, okay, and think of botulism in canned food. So we require them to pasteurize. You have to go through your plant once a year, and you have to actually draw a diagram of what your plant works in, everything that you're doing, and how to make sure that you don't have botulism in canned food. Okay, and all these reports go to FDA, and FDA takes all those reports and they have them in a really big file that no one has ever looked at. So I think, that's just little things, but they're also trying to look at regulations and saying, what do we really need to do? So for example, I mentioned retrospective review. This is a law. You're supposed to go back. It's different laws and say, look at this regulation. Does it work? Is it doing any good? Agencies simply don't do it. I mean, it's so rare and piecemeal. So we need to do that. I think the way to do it is to just do it wholesale.
One last follow-up question, because it segues to Dr. Brian McMillan, because he's with the American Enterprise Institute, where they like enterprise and competition. Is there a free market aspect? There's been a movement on the libertarian side of the aisle that said forever there should be no government. What we should have is basically a private sector version of what the Jewish faith has, which is inspectors who stand by their inspections, and you can hire different inspectors and they stand by their work and on and on. Is there an aspect for that, or is that just not possible?
No, absolutely, absolutely. So the first thing that you do is you pull back this whole idea of people writing regulations that impede the market, and you also are creating basic science that will help spur more innovation. Okay, this is something that government can do. You clearly do need a police function. That's a role for government, but it's got to be smaller. We don't want to go out and for every single tiny labeling violation, gig people. So yeah, I'm definitely a pro-market guy. I think this makes markets work much better.
So pro-market, see, Dr. Brian Miller. And I want to ask you the same question about public health today from your vantage point. Also tell a little bit about your background, if you don't mind. And what is the one thing, the one simple idea that we could use to help improve public health?
Well, thank you for having us all here. I'm a practicing hospitalist, actually, at the Johns Hopkins Hospital. I'm a practicing hospitalist at the Johns Hopkins Hospital and a non-resident fellow at AEI. I have the distinct pleasure of having worked at the alphabet soup of health regulatory agencies, as I call it, the variety of 3-letter agencies that sometimes prompt people to use 4 letters to describe them. But I worked at the Federal Trade Commission on competition policy and consumer protection issues related to healthcare. Worked at the CMS Innovation Center on payment models and payment reform. I also worked at the FCC on interoperability and health tech, and then also at the FDA and policy, and a distinct pleasure of being a reviewer buried deep within the bureaucracy at the Center for Drug Evaluation and Research. So I'm very familiar with many of the regulatory processes that touch healthcare. I think the one that has always interested me, because you asked about one idea, one common sense idea, is having the CDC focused. And it sounds sort of like your mother telling you to do your homework or take out the trash or do the dishes, but it's really that simple. So I am a physician. I was a physician during the pandemic, and I worked in the hospital, right? And I saw COVID patients, and I saw more COVID patients, and I worked on COVID wards in the hospital, the COVID only floors, and I worked in the COVID screening clinic, and I worked in, you get the idea. Normally during a pandemic, you go to the CDC for advice, right? Like on guidance on something of, this patient had COVID, how many days do they need to remain isolated after they leave the hospital so they don't transmit it to their family? What is the appropriate anticoagulation or blood thinning strategy for patients in the hospital? What are the appropriate therapeutics? What is the diagnostic performance of COVID tests, right? Well, you're in the middle of a global pandemic and the entire economy is shut down and people are confined to their homes and you're going to the hospital and you look up the CDC guidance and the webpage hasn't been updated, or they don't know, or they're not having press releases, or they're issuing guidance documents through MMWR months later, right?
What's MMWR?
That's the CDC's
Morbidity and mortality.
Morbidity and Mortality Weekly Report, which is a non-peer-reviewed scientific publication. Ironic that it's not peer-reviewed. And so then, you're in policy, right? Like you can get angry and throw a temper tantrum, and once you get past that phase, you start to think about what you do. Like, how do you solve this problem? And the answer is that the CDC's mission has drifted. So the CDC has focused on a variety of things that are important in public policy. I think we can all agree focusing on the environment is important, focusing on issues like racism, gun violence. These are important public policy issues, and these are things that our country should have a debate. The problem is who should be having this debate and which agency is best equipped to address these public policy questions. So environmental health and climate change, for example, would you like the CDC focusing on that? Or would you like the Environmental Protection Agency, which in its very name and statutory authority is the foremost environmental regulator? And so it's not that a lot of these other public health issues aren't important, because they are important and we should spend time and energy focusing on them. It's just we should have the right agency focus on them. Having an organization that is trying to be all things to all people all the time means that it is unable to perform its basic functions, as we found out during the pandemic. A classic example, I guess, would be data collection. There's a big push in public policy right now to give the CDC statutory authority to mandate data standards and data reporting from local and state and territorial and tribal health officials. Well, another organization, the Johns Hopkins Coronavirus Resource Center, was able to successfully report case data when the CDC was not. And the last time I checked, public and private universities do not have statutory authority to collect data. So I think that part of this was that the CDC, in focusing historically on communicable disease, as we made that transition in our society where many of the public health problems that we face are not always related to communicable disease, the CDC wanted to remain in the news, right? And it wanted to continue to have that important public policy voice. And as a consequence, its mission drifted. And so then simple things like thinking about how we develop how we develop diagnostic testing during a pandemic. Anyone have an idea of how the CDC went about that? Any of my colleagues? Did they? Yeah, so they had one channel. They were doing an internal development. Now, most of us are relatively business or policy savvy, and we would say, well, during a global pandemic, you probably should have a multi-channel test development strategy, maybe call Quest and LabCorp, call a couple academic centers, have the CDC develop it internally too. CDC didn't do that, and we lost valid time and important time. And again, that's because those muscles that the CDC had for identifying and working on communication and containment strategy for communicable disease weakened over the last 30 or 40 years.
So let me follow up on a couple of things. One is, so you're saying the CDC was working on issues like climate change and social justice, that they were working on those issues?
Yeah, and it's not that those aren't important issues, because they are important.
So the communicable disease aspect would be what? I mean, I don't even understand how you, like, where's the handle on that ball?
Frankly, they dropped the ball, and the ball has still been dropped.
So that's the off-mission part. How, if the CDC were refocused on the task of addressing communicable diseases, whether it's the 1917, pandemic, or whether it's the annual impact of communicable diseases in the U.S., like flu, which we were all reminded by COVID kills tens of thousands of people a year. I mean, are you saying that that's the mission they're not on as they pursue these other things, and there's more progress to be made?
That's right. And then also the other missions that they're spending funds on, they're not doing they're not getting the return for taxpayers, right? So I think we can all agree that our society, unfortunately, has had an increased rate of obesity, an increased rate of diabetes, hypertension or high blood pressure, and we haven't really been successful yet. The CDC has spent over $1 billion on those chronic disease programs over the past several years. And so if we're going to be responsible as a society and say, we care about, obesity, we care about diabetes, we should be directing our dollars to policy levers that work. And funding the CDC directly for those activities might not be the best policy lever. Like, there are other policy levers that we can pull. And then as an example, a lot of public health is local, right? Like, decisions are made locally. Disease, yes, you can have a global pandemic, but there are also local outbreaks, local surges. We should also be focusing on supporting local health departments as part of retooling public health infrastructure.
So my understanding is that when it became clear that we had this new virus that was going to be a significant problem, that the CDC, you mentioned the single tracking of that there were tests were apparently already being developed by individual doctors and labs because they had the cases in front of them, and the CDC said, no, it has to be my way.
Yeah, the CDC wanted to have an internally developed and managed test rather than serving as a coordinating nexus and center for the development of university-developed tests, private physicians and labs developing tests, and, as I said, the two major national testing corporations, LabCorp and Quest. So the CDC sort of lost its focus, lost its ability to serve as a guidance and logistics and strategy organization, which is important for public health response, because they were focused on things that, have urgency over a course of years or decades, as opposed to hours, days, and weeks.
Should we have basically the fire station model for contagious diseases, communicable diseases, so that if we have pandemic 3.0, it's break glass, ready to go? And wasn't that supposed to be CDC, or was that?
That absolutely was the CDC's original mission, starting over 70 years ago, and with the Epidemiologic Intelligence Service, which is or the EIS as it's known. It's a training program. You go through 2 years, you learn how to do epidemiologic modeling, you learn how to do disease outbreak investigations, assist local officials. That's something that we should think about expanding. We should think about, directing the CDC's resource to its core mission, and then some of those other funds and staff that are spent, give them an opportunity to participate in that core mission, or think about other agencies in the government or other private market actors that can accurately and better fulfill that mission. As said, environmental health and climate change, I would much rather have those resources spent at the EPA than the CDC. And then
one last question before we go to Clive. If we did have this focus on the common communicable diseases that result in significant health and death, and once again, we learned through COVID just how traumatic something like the flu can be for older people, and you will look at the death rate differential. I mean, we all assumed it was going to be significant, but when you look at the death rate at 75 plus for COVID, and then you look at the death rate for 20 under, and it's almost non-existent to, oh my gosh, that you realize there are a combination of factors out there that put people at risk to these diseases that we kind of shove off. Is there room to drive down the flu death rate, the other diseases that attack the lung death rate? Is there room there, or are we doing the best we can? I mean, would you trust the CDC to do it right? Their standing is not that great at the moment. If they came out with new regulations, I don't even know how many people would want to follow them.
So I actually want to pull on that regulatory thread. So there are, I think, two things. One is that the public doesn't have an opportunity to participate in the CDC's vast public health regulation. Right. So all these other agencies that I worked at, CMS has rulemaking, people can make comments. I think we can all agree that reading a 1,500-page payment rule is probably not accessible to the average American, but they do have that opportunity. The CDC the FDA publishes a series of guidances. They're anywhere from 10 to 30 pages. People submit comments. They also do rulemaking. The CDC doesn't use either of those processes. So in terms of what I would say good practice for being a regulator, and the CDC is a public health regulator, we should have a thoughtful discussion about how we can have the CDC use rulemaking, use guidance, and have a clear, transparent process for public input from stakeholders. So it's not just friends of the CDC director or friends or of whatever administration happens to be in power, be it Democratic or Republican, that the public can participate. And be it in a non-urgent, urgent, or even emergent setting, public opinion still matters and public input still matters. And then on top of that, the CDC had challenges engaging in what I would call risk-benefit decisions. They focused primarily on risks, and they were unable to think about benefits. And then economic impact, right? So losing your job is a big deal for affecting your health, right? Like if you lose your job, maybe you can't pay your mortgage or your rent. And if that's because of a lockdown, and we didn't think about the potential risks and benefits of lockdowns, we need to hold the CDC accountable for that.
Thank you. I appreciate it. So Clive Bates, by the way, we're glad to have you. I know it was short notice. You were at the coronation. You almost didn't make it. Your buddy Charlie. By the way, I learned something about British people. They don't all have consorts. So don't ask about how's your consort. That was not good when I met Clive. But no, we're glad to have you here from the Counterfactual, and you do a lot of writing across the spectrum of public health. So I will put the question to you. The one simple, straightforward thing we could do that have an immediate impact on public health.
All right. The visible from space thing that you could do, you can get rid of almost all smoking in the United States, given enough time. You can do this by harnessing the processes of innovation, creative destruction, market forces, and you can do it so that people do it to protect their own health on their own initiative and at their own expense. It needn't be a big burden on the federal government, state government, or anybody else for that matter. The main problem, the main role for the government is to basically stay out of the way of those processes, which it has not done, and we'll go into that in a bit more detail in a minute, and try to make them work as best as they possibly can. So it's trying to improve what is essentially a private sector process driven by the agency and volition of people at risk to reduce their own risk. Okay, so that's basically the proposition. The issue, first of all, the problem, it's a terrible CDC number that hasn't changed for about 2 decades, but 480,000 a year people die from smoking. Another 16 million people live in some sort of misery from smoking-related diseases. There are pronounced socioeconomic gradients, education, employment, mental health, and so on, which mean that these problems are concentrated in the poorest in society. It's very strongly associated with disadvantage. So if you can do something about the problem, you can do something about health disparities as well, which is a good thing. Now, the basic mechanism that we're talking about is that really since around 2010, there have been emerged a set of products that allow a user who smokes to switch to using a product that provides nicotine but without combustion. And the problem has always been that the nicotine doesn't cause the harm to people, it's the smoke that delivers the nicotine to the lungs and from the lungs into the blood and then into the brain. And if you can get rid of the smoke, you can get rid of almost all the toxicant exposure, and people will continue to use nicotine, but at much, much lower risk, and probably 1 to 2 orders of magnitude lower risk. Agencies in the UK have said 95% lower, at least 95% lower risk. The National Academies of Science, Engineering and Medicine said very much less harmful was their particular form of language. We also have considerable evidence now that these products do not add to the problem, they displace smoking. So we know this from randomized controlled trials, observational studies, population trends, economic data about what happens in markets when prices change and so on. So we know that these products displace smoking when they're allowed to. I should talk now about the mechanism by which this works, because it explains why the federal government is preventing it from working as well as it should. Okay, so normally when we think of smoking cessation, you'll go to a doctor or clinic or health professional and they'll say, have some medication. This medication will help you deal with the withdrawal and cravings that you get when you give up smoking, give up nicotine. And if you stick with it, you'll be all right, you'll get through it. Of course, most people don't. Most smoking cessation efforts fail, and they fail completely fairly quickly. This is a different way of doing it, okay? This works through consumer choice. So it's not a medication designed to deal with withdrawal and cravings. It's a different way of taking nicotine. And it's pleasurable, and people like doing it. It's fun, and they like to use. They continue to use nicotine as they had before. Now, a lot of people object to that. They're like, well, we're not in the business of supporting drugs, but it's a harm reduction strategy. It says for people who wish to continue using nicotine, these products will be vastly less risky, and they really are much less risky. So if you can get people to substitute, then they will. But for them to substitute, the products have to have characteristics, like they have to be appealing, they have to be enjoyable, pleasurable, they have to be branded, they have to come with some kind of image. And regulators struggle with those concepts. In pharmaceutical regulation, those concepts go under the heading of abuse liability. So they would be things that make you use something you shouldn't use. So they don't really have at FDA a lexicon for dealing with the concept of fun or pleasure. I think you probably all know what I mean by that. It's not a place you would immediately.
That's not what the F stands for?
No. So they don't really know what they're doing with these things. And the example I use is say, well, you're better off thinking of these products in the same way we think of other recreational drugs like caffeine, modest alcohol consumption. Now, if you handed craft beers to the FDA and said, could you please regulate them? And they said, well, yeah, they have to be appropriate for the protection of public health. People look at you like you've gone insane. What are you talking about? It's beer. It's not going to be appropriate for the protection of public health. It's beer. It's not the point of beer. It's there to be enjoyable and enjoyed. Okay, so there's a mindset, a paradigm problem with the way FDA approaches these products. And the way that plays out is appalling. So because of the way the legislation and regulation is constructed, there's around 3,000 cigarette products, distinct cigarette products on the US market now, with a turnover of around $80 billion. So it's a massive market, and it's pretty well ungoverned. I mean, there's a few rules and warnings, things you can and can't do, but basically the manufacturers of those products are largely untroubled by regulation. If you want to put a much safer product on the market, that's a massive evidential hurdle that you have to cross, and the barriers to entry are phenomenal. FDA had 6 million applications for new products to come onto the market, these safer products. So far, it's rejected nearly all of them, well over 5 million, and it's accepted 7. 7 distinct product systems have been accepted. They're all basically the same.
There were 6 million,
6 million
applications, and not 7,000 or 7%.
No.
As in 7 fingers.
This is a classic 3 orders of magnitude error in FDA's regulatory impact analysis, where they misunderstood the market they were dealing with by well over 1,000 times. I mean, it's ludicrous. They did not know what they were dealing with. Their answer to that is not to conduct 6 million detailed applications. It's to find reasons to reject them as quickly as possible. And the way they've done that is to raise the evidential barriers to entry as high as possible, so that even products that are appropriate for the protection of public health bounce off this wall of evidence requirements, simply because the companies are too small and too pressurized and don't have the balance sheets to clamber over that wall. Even if their products are perfectly good for public health, they just can't participate. So the result is we've had 7 kind of systems have been approved, almost all by big tobacco companies or big vaping companies. And those products are coming from companies that can essentially cross-subsidize their vaping operations from their smoking operations, and they've got the balance sheets to deal with the costs and burdens. Everybody else is just wiped out by this. So, of course, we're in the courts, the United States, of course, we're in the courts, and there are, there's endless litigation about whether this is fair, whether FDA has conducted itself fairly, changed the rules, is imposing de facto standards without going through the rulemaking process for standards and so on. So it's a chaotic mess. Almost everything on the market is unlawful in some way and is only there due to either enforcement incompetence or enforcement discretion. Nothing is working as a good regulator would want it to work. The net effect of this, combined with lots of negative communications from CDC, FDA, just about everybody in the picture, is that we are grossly underperforming the potential of this market-based intervention to deal with smoking and the burden of smoking-related disease. And the main thing that FDA has to do is step back. Brian's very good on this. Impose a few standards or use what I call soft standards, so comply or justify type standards, which expedite these products through the process, use rules for entire categories rather than each individual product, and just make the whole thing much more streamlined and much more open so that we can get on with the creative destruction of the cigarette and the burden of tobacco-related disease that goes with it.
No, please go right ahead.
Maybe respond. I can steal your microphone.
Steal away.
It's actually sort of ironic, right? Because you have a regulatory system designed for tobacco products that ironically favors the large incumbent tobacco companies over small competitive manufacturers, and also favors combustible cigarettes over e-cigarettes or electronic nicotine delivery system products. The other sort of thing you mentioned, product standards. The challenge is for some reason at the FDA, the regulatory centers, there's a different sort of standard of oversight, I guess, for the Center for Tobacco Products. So if this happened with medical devices, biologics, small molecule drugs, or foods, there would be a massive public health and political and combined industry outcry. With tobacco having marketing decisions made for over 5 million products without clear elucidation of what a product market standard is for a marketing authorization, there's deafening silence, which is sort of impressive to me. And also, if you think about it, in device regulations, normally we have consensus-driven standards where there are standards that the FDA recognizes that are sort of like Lego building blocks for reviewing applications. For some reason, we don't have that with tobacco products. So all these basic sort of regulatory good practice functions that the FDA uses for almost every other product market regulation, we don't have for tobacco products. And the FDA is sort of sitting there with its arms crossed saying, I don't like this marketplace, so I'm just not going to deal with it. And it's like they don't have to like the marketplace, but they still need to address it and do their job as the law requires to protect the public health and be a good functional regulator.
Just a quick one on that.
Please, go ahead.
I agree completely with Brian on that. In most regulators, a burden is regarded as a bad thing. It's a bug, not a feature. When it comes to tobacco, the reputational baggage is so bad that almost any cost or any burden or any restriction is seen as a feature rather than a bug in regulation. It's deliberate to make it the path to market as difficult as possible, even though these reduced risk products deal with most of the problem that we hate the tobacco industry for.
So we got a ton of thoughts, and that's what I want to do real quickly, because we've started what I wanted to have happen was conversation. I want to drag Dr. Williams into this on the FDA side, but also I want to remind the folks who are listening and viewing via the stream, whatever outfit you're with, journalists or think tank, whatever, you can ask questions. There's a question feature on the screen where you're watching. Just type in the question and it'll be transmitted to me, and we will make sure that we get these questions. And if you're working on a story and you want to grab a quote for something, you've got the next 20, 30, however long this lasts to do it. So use the question feature on your screen. If you're at home, if you're here in the room, we'll get you up in there in just one second. I want to ask you about the attitude inside the FDA towards the tobacco product, because they make a very good point about how beer is not vitamins, and you have to have this different mindset. And part of that, the problem of having the FDA trying to regulate something that is so counter to the other products and the culture that they're, every day. How do we keep this, baby formula that might be tainted out of your mouth? And wait a minute, you're going to put that in your mouth 2,700 times today? What am I going to do about that? Is that part of the problem?
Yeah, I mean, so first of all, there are two ways that FDA operates. One is they approve or disapprove products. And that's a completely separate way as opposed to regulations. So when FDA has the power to approve products like drugs or food additives, they set the standard very high, because the standard of proving that something is safe, which is kind of a joke of a term, falls on the person who is trying to submit it. On regulations, the problem, it falls on them. Now in regulations, there's by law, the Administrative Procedures Act says you have to respond to every comment. You don't have that in approvals, but even in regulations, there's two things that FDA says. If you send in a comment and they don't like, they say, you didn't send us enough data, so we're not going to pay attention to you. Or even worse, and they say this all the time, the FDA disagrees with you. Period, end of story. That's the end of the problem. This idea that somehow, and particularly the vaping products are more dangerous than other things, everything is dangerous, all right? Everything is a poison. It's the dose that makes the poison. So just for example, they don't say this about drugs that FDA approves. Do you know how many people die from taking legal drugs every year approved by FDA? 128,000 is the average. So this whole idea that we need this higher standard for vaping, it's kind of ridiculous.
And then to follow up on that, because that was the question I was going to ask the three of you, is the concept of risk. And I'm going to start with you, Clive, and then kind of work your way down. I feel like that we as a culture are struggling with this. For example, the CDC and COVID. The concept was, well, if one child is at risk, then we can't have the schools reopen. Well, guess what? You kept the schools closed, and now those kids have suffered, and whether it's from mental health and depression to setting them back economically because they lost 3 years of their lives, and so in the future, they're going to have the impacts of that economic setback. There was real harm done because no one would answer the question, we can't put one child at risk. The answer needed to be, well, yeah, first of all, there's not really a lot of risk with children, and secondly, we do need to put some kids at risk because the big picture is just, well, I don't know that we're prepared to have any conversation about risk management and risk assessment. The answer seems to always be, if there's any risk, say no. So say no to vapes because there's some risk, say no to schools opening, because say no to fixing the FDA, because if one thing goes wrong, it's not worth the price. Is that part of the conversation?
Definitely. I mean, the discussion about risk is unbelievably infantile, as you imply, Michael. I think you have to distinguish different types of risk. So communicable disease risks are a very different beast to non-communicable disease. Where one person's behavior or actions affect somebody else, you tend to take a more restrictive and precautionary approach. Risks that you're taking on yourself, we generally have quite a high tolerability of risk and appetite for risk in society. So we have people who go off and do base jumping, free rock climbing, horse riding, all things. If you set an objective risk standard, you'd be like, oh my God, you cannot go horse riding. It's literally the most dangerous thing you can think of doing. You cannot play American football. You cannot, those are things that we opt into that are pretty strong risk behaviors. We allow people, we are content with people drinking quite heavily, put themselves at considerable risk of accidents, and so on, sometimes affecting other people. So you're right. I mean, the map of what is an appropriate risk to take on yourself, to inflict on others, is complicated by the idea of naivety in children. So do you allow a child to take on more? And this is where a lot of the debate, to get around this, people say, well, kids are at risk of vaping, and therefore, there's a predatory industry hooking kids to get them as customers while they're adults. So the risk argument is laden onto children, and that is then the basis for the control architecture that's applied to the product. And it's also, again, sometimes complicated by addiction. People will use that word, say, well, that's a suspension of free will. So whilst it's a consumer choice to take on these risks. If you're addicted, it's no longer a choice. So again, there's a nuanced discussion to have about these things and about how much child protection we do. We see risk behaviors everywhere with adolescents. You know, if you look at illicit drug use, you look at gang participation, you look at driving while distracted, all of these, none of them are good, but we just recognize that they are a phenomenon in society, and we try as far as possible to reduce the risk to the people that are engaging in those behaviors.
Yeah, so I would say for the CDC, as you said, the benefit risk is what it sort of needs to adopt rather than just risk. Going back to the FDA, it's actually interesting because the other product centers at the FDA, devices and drugs, think about benefit risk very clearly. What's weird, again,
What do you mean by
the benefits of using a drug, a prescription drug, or a medical device, and what the risks or potential harms are from that. And if you look at a drug label, which I realize like the average American's not reading that, but you know, the physician who is prescribing you the drug is looking at it.
Wait, you mean there are more words than all those words at the end of the TV ad that seem to go on for, like the ad's a minute long and 10 seconds is an ad, and exactly 50,000 exactly.
Events. So it's like the physician is helping the patient make that interpretation and saying, I recommend you take this drug. Here is what it can do. Here are the potential side effects or potential adverse events. With other product spaces, the FDA has, namely tobacco, and also, frankly, for cannabis, which is another space that the FDA will eventually be regulating, cannabinoids and cannabis. If you look at the Cannabis Opportunity Act, it said that the FDA shall have a center and it shall regulate cannabis. If we don't get tobacco regulation right, how are we going to get cannabis regulation right? And part of that is being a good product regulator. Part of being a good product regulator is thinking about how those products are advertised and how those products are distributed, right? Like we don't have opioids available in vending machines, right? You have to go to a prescription, see a doctor. There's prescription drug monitoring databases that the physician is supposed to look into. And so those sort of basic advertising and distribution questions we haven't fully answered. And when I say we, I mean really the FDA hasn't fully answered, right? And so when you think about consumer protection in children, those are key levers, but you have to address them, and you have to address them in a thoughtful and systematic fashion in conjunction with the states.
Dr. Williams, risk?
Yeah, I mean, this is something, it's funny, you know, there's a lot of things that you have to take in college, and one of them is not toxicology, and maybe that's a shame. The founding principle of toxicology goes back to 1600, Paracelsus. He said, all substances are poisons, all of them. There are none that are not. It's the dose that makes the poison. And yet, that's something, toxicology, that pretty much should be the gold standard at FDA. If you go on FDA's website and CDC's website, they will say, there are no safe tobacco products. I'll go them one better. Nothing FDA regulates is safe, is without risk. In fact, there's nothing in life that's without risk. And so we're always looking at trying to get less risk. That's what public health is all about. It can be called risk reduction or harm reduction, whatever you choose. And unfortunately, they don't do that. I read something else in the tobacco front. This was a survey that FDA did, and it was greatly concerning. They said, we have looked at, it's less than 1% of teenagers have smoked one flavored cigar or more a month. Like one cigar a month. Where is the exposure you're actually concerned about? But that's constant. So FDA should be talking about risk and not safety. And when you're talking about risk, you have to be concerned that everything is some risk, no matter what you do.
And you have to have risk-based regulation. What's ironic, I think, about the FDA is that people forget it was the American Academy of Pediatrics that was suing to have the FDA make marketing decisions on e-cigarettes, right? So the FDA had existed in a regulatory vacuum until the pediatricians knocked on their doorstep with an army of lawyers. Like that just to me says everything, actually.
And then that raises to me a question. And by the way, once again, we've got some questions coming in on the phone, and I'll get to the crowd here in just a second. But one of the big stories around COVID was when it was discovered that there was communication with a large union about school reopening, and they're setting aside the politics of whatever. Who the heck? Why are you asking these people in a the union to make this decision that supposedly the Center for Disease Control is in charge. And then what that raised the question to me about is across the spectrum, whether it's, well, there are groups that don't like vaping because they see teens doing it and they just don't like it. And so they get together and they call people and they complain to legislators, and the pressure's a lot. And so that's the regulation. It's not science. It's not risk. It's not, 100% or 100 times, excuse me, less risky. Moms don't like it. Schools, teachers don't want to open, teachers can't, on and on. How much should people be concerned about the impact of non-science, non-health, non-risk actors, whether it's the industry on FDA and food health, or whether it's, moms who hate vaping who are having an impact on the decisions these agencies are making? Clive?
Well, everything's political, so they should take that into account. I mean, that the idea that there's some sort of I don't know, technocratic utopia where people take in science and then work out some economically optimum thing to do, balancing costs and benefits. It's just not true. It's not how things work at all. What tends to happen is that essentially a policy prior, which is usually based on visceral instinct, is advanced, and science is brought into the service of advancing that policy prior. That would be a more typical way that governments or agencies use science than the other way round, in which they start from it. So I think you have to. I think you have to. The fact there's a large number of moms don't like vaping is not something to wave away. In a democracy, they're voters, they're citizens, they're worried about their kids. One of the problems is that they're usually incredibly misinformed by a stream of, I would call it propaganda, that would tell them that vaping is as harmful or more harmful than smoking. And I think it's now around 60% of Americans believe that vaping is as harmful or more harmful than smoking, which couldn't be more wrong. And then about another 25% just don't know, so they're confused. And you've then got, so if you don't know, or you think it's as harmful or worse, and you're seeing these kids vaping, of course you're concerned. It's like this is something we fought for years to get rid of. So the agencies like FDA and in particular CDC need to take their responsibilities about risk communication much more seriously than they do. And the way that they operate at the moment is, well, we don't want kids to vape, so let's big up the risk. Let's make it seem as risky as possible. Let's talk about heavy metals, diacetyl, popcorn lung, EVALI, seizures, you name it, a long sort of litany of things that when you investigate with the dose, the dose makes the poison mindset, you find there's nothing to it, or it's some incredibly speculative thing that, nicotine is a brain poison and causes brain damage to teenagers. Yes, if they're teenage rats, and yes, if you immerse their brains in liquid nicotine, yes, something bad happens to them. That is in fact, but that doesn't need to be put on a campaign run by the FDA at significant expense and blasted out to the public in order to deter kids from using vaping products. So that's, to me, an incredibly irresponsible and reckless thing that CDC did this with there was an outbreak of lung injuries in 2019. About 3,000 people hospitalized and about 68 died as a result. It's a very serious outbreak. CDC discussed this in such a way that it looked as though nicotine vaping was responsible, but it wasn't. It was a contaminant in cannabinoid vapes, THC vapes, okay? But if you think about it, if the change in perceptions just caused smoking behaviors to shift by 0.01%, okay, that would be 3,000 extra smokers in the United States. It's 30 million smokers, 0.01% is 3,000. So tiny shifts in behavior as a result of shifts in perception can cause enormous amounts of harm. And yet we don't really count these numbers, and we certainly didn't hold CDC accountable for the incredibly irresponsible way that they treated the information about that lung outbreak, because they used it to try and dissuade people from taking up vaping. No doubt about it, it was deliberate, the confusion that they created there, because they thought they would get some operational benefits from it, stop people taking up vaping. But the danger is, as a result, more people continue to smoke.
I was going to say the irony about EVALI is it's product adulteration, which is a failure of basic FDA product regulation. So that, you know, where was the FDA when they had vitamin E solvent?
Because it's an unregulated product, because it's illegal.
Right.
So this is
Right, but the point is
an argument for
having
legalization and regulation against for recreational.
It's also an argument for a functional tobacco regulatory product
I agree
regimen. I think the other thing, so we talked about benefit, you asked about benefit and risk, and also about including non-science-based actors. I mean, we all of us have opinions on all kinds of things, which, you know, we're not qualified to have opinions on. I have thoughts on space policy as a science fiction fan, but I don't think, you know, that the Assistant Secretary for Defense is going to be asking Brian Miller's deep thoughts on that. But the point is that in a country where we are, where you have freedom of speech and freedom to have opinions, thoughtful or otherwise, like, we should create a venue, and all these agencies, and some of them do a better job than others, for everyone to have their input heard and have that voice heard and be part of that policy conversation. I think that's the CDC's challenge going forwards, is to create those processes and learn from the other agencies. While imperfect, they have those avenues and channels through rulemaking, through guidances, through public meetings, through workshops. The CDC needs to do those things.
Do the businesses that get regulated by FDA have an influence on the FDA?
Oh my gosh, yes. Particularly if they're large firms, they get a lot of say. But I wanted to respond to some of this. You know, one of the problems, I think, and activists have a great role to play in here, that to draw attention to potential problems. Typically, what they do not do is they worry about unintended consequences. So, for example, years ago, we had a lot of activists saying, you know, you got to stop eating red meat because of the high levels of saturated fat. And so we got rid of a lot of the oils, the animal-based oils, and what replaced it? Trans fatty acids, okay? I remember going out to dinner with my good friend, Michael Jacobson. I said, Michael, what happened there? You know, he goes, well, we didn't know about trans fatty acids. I said, well, isn't that the problem? You literally have to know what's going to replace something that you take off the market. Or if you don't allow something on the market, if you don't allow vaping devices, what are people going to do? They're going to do something. It's not like they're just going to stop. They're going to do something. And that's the question. What is that something that they're going to do? Because again, we'll go back to everything is risky. Right now, FDA has a program called Closer to Zero. And this is about metals. It's about pesticides, additives. The idea is to get these things as close to zero. Well, what, for example, if it's a food additive and you take it off, what replaces it? Well, it'll be another food additive. Will it be more or less risky? They don't look at that. Okay, they just say, let's get it closer to zero. And frankly, most things, pretty much everything, there's a level at which, a threshold below which there's no harm. I mean, think of botulism. It's the most dangerous compound known to man. We use it in 3 different medical uses. Besides skin tightening, it's used. So mustard gas, it was banned in 1925, right? I mean, this is horrible stuff, right? Well, it's actually used now in surgery. So, I mean, all of these really, everything's dangerous, right? And so you have to start thinking about dose response, risk, not safety. You have to think about risk, and you have to make decisions about risk.
Okay, so I want to open it up to anyone here on the floor who might have a question, and also I've got some from the folks who are viewing on the stream who would like to start. Okay, if you don't mind, by the way, everything you say could be on the record for publication, just so you know.
Okay.
So introduce yourself.
Gregory Conley with the American Vapor Manufacturers Association. Thanks for holding this event today. Shortly before the event began, some news broke that I'm sure interests Clive, that Matt Myers is stepping down from the Campaign for Tobacco-Free Kids. I was curious what you think that his legacy on the issue of harm reduction will be, and what his role has been in confusing Americans or confusing legislators on this issue.
I don't like to get personal, Greg. I think there was a time when that organization could have taken a different path. It could, and I think if one of Matt's former colleagues, Judy Wilkenfeld, had survived long enough, it probably would have done. They could have embraced the public health mission here. I think what's happened in the tobacco control world is that there's a split. People have different motivations for working. And my motivation is all about cancer, heart disease, COPD, strokes, all the serious diseases that people suffer and all the harm and mess that's caused by this. My father was a victim of it, been in my family for many years, and I feel quite strongly about it. The other way that people approach this is a kind of as a drug warrior. They're kind of like annoyed by other people's drug choices, the fact that people want to use these products when they have no need to, in their view. You know, even if they're at a tobacco control conference having a strong coffee in the morning and a few beers after the closing session in the evening, they're quite happy to be very vehemently calling for a nicotine-free society, and they think it's just the wrong kind of drug to be using, just as people used to say the same thing about cannabis. And I think that's the direction that Matt Myers took the campaign into more of a drug warrior mindset. He played the kids thing mercilessly in doing that as an alternative to the harm reduction approach. Whipped up an enormous moral panic when youth vaping went up at the end of the last decade. He shouldn't have done. There was no need to do that in public health terms. It looked bad on the graphs, but it was people vaping once or twice a week, going to parties, blowing silly clouds, messing around, being kids. The interesting kids were what, you know, other academics would call the bad kids, the kids that, you know, prone to substance use, come from tougher backgrounds. For them, they were vaping more frequently, but they were vaping instead of smoking. And for them, for those kids, the kids that matter most in a public health context, for those kids, that this was a beneficial trend. And he allowed the headline numbers of frivolous and experimental use to drive the narrative, and he was, you know, prime mover in doing that, when he should have been thinking more carefully. Even if his mission was focused solely on kids, he should have been thinking more carefully about the kids with the problems, and he wasn't doing that. More generally, I think the tobacco control movement needs to refine its mojo and focus on where the public health problem is, which is essentially not very telegenic, middle-aged, poorer smokers who are the people who are at the most mortal risk from tobacco use. It's not the kids, even if they are telegenic, it's the middle-aged adult smokers. And he made that big strategic error in going into a war on drugs mindset and focusing on kids, when he should have been taking a public health mindset, focusing on disease and adults at risk of disease. So I shan't mourn his passing. No doubt somebody just as bad will replace him.
Anyone else with a question? Okay, well, I've got a question from one of our writers who says, what can average people do if they're upset with the FDA or CDC? And it reminds me of a friend of mine who, they had a young infant during the formula panic. And the wife was running around, you know, they had networks on Facebook. I found some formula. He got so mad. And I remember him saying to me, I don't know who to complain to. The store's not messed up. The store didn't do anything wrong. I know the baby formula company wants to sell me as much as they can. Who do I get mad at? So, Dr. Williams, who do they get mad at?
They should get mad at FDA. And frankly, I think we're seeing more of this now. We're seeing more people who are very familiar with one or more of the FDA operations. I've seen it. There's a recent book out in 2021 about drug approvals, how that's gone wrong, how the whole efficacy approvals really are completely don't make any sense at all. I've written a book about foods. We have people who are writing about tobacco. Look, this is a very, very old organization. It's 117 years old. Very few firms in this country last that long because they become stagnant. They become too vested in a certain way of doing things, and they kind of get left behind. And that's where FDA is. So I think it's time to start writing your congressperson and saying, what are you doing about the FDA? And please don't tell me that you've gone out and you've hired 3 FDA commissioners and they all said, well, the problem is FDA needs more money and maybe more authority. Please don't do that. Let's talk about real solutions for people. Let's say when FDA comes and say with their budget request every year and they say, hey, here are all the problems that we're handling. They're big problems. We need big money and they're getting bigger. We need more money. No, the Congress say, what are you doing? If you can't solve it, we're going to find a way to solve it. And there are ways to solve it. And that's what we're doing. So get Congress involved. Don't let them off the hook.
You know, it's funny when you talk about 3 former FDA commissioners saying they need more money and more funding. I also heard the same thing about the CDC, that they need more statutory authority and more funding and more staff. As the millennial, I'd actually sort of echo your thoughts, which is vote and go talk to your congressional office, because those are the sort of 2 levers that you have available. If the person wants to, you can get involved in the public policy discussion as an individual. It involves a lot of reading and a lot of talking and a lot of listening. There was a question earlier about activists and not just about Matt Myers and Campaign for Tobacco-Free Kids. I think activists actually have a really important role because they often, as you mentioned, they point out problems that we might not be aware of or that, the regulator might not be aware of. The public policy community has, I think, a sort of moral responsibility to engage with activists, even though we might not always agree with what they say, depending upon what the issue is. Having that conversation and finding a joint pathway forwards is, I think, one of the things that has actually helped improve agencies like the FDA and CDC historically, and we should continue that.
So I want to add something to that. New Hampshire Journal, one of our properties, they had a couple incidents stories a while back where the local state public health office sent out a tweet. Climate change is causing PTSD. Protect your public health. Help us join in the fight against climate change. Back to your CDC model. So New Hampshire Journal wrote a story about this. Why are you talking about this? What the heck? And is there any? And it said storms were getting more severe and more frequent. Well, that's just factually not true. So 4 days later, they sent out another tweet. Vaping is tobacco. Stay away from vaping, says the New Hampshire Department. I happen to know because I know Clive. That's not true. And finally, what happened is the governor of the state had to get involved to send a message down to whoever runs the Department of Public Health, whoever runs that division. And sure enough, there was some 20-something kid tweeting out fun. This is, hey, I heard this on whatever, a TV show. This must be real. And that disconnect between data, the mission, the only person who could intervene was a political person. But for example, on the CDC, as angry as many Americans are about CDC, I don't see a lot of political blowback to the CDC. Dr. Miller, do you? Or either one? Sure.
Well, I can pick up on that point because I think the sort of ad hoc approach to Congress dealing with these agencies, CDC and FDA, is wrong. What's needed is a more systematic approach to oversight, and the ordinary citizen should be feeding into that oversight process. So in the UK, for example, we have Parliament. I mean, the behaviour of FDA and CDC, the equivalents in the UK would never be tolerated. They would be incinerated in Parliament if they carried on like that. Okay, and the reason is we have select committees that scrutinise them in detail. They're standing committees and they scrutinise them, and the public, they create a venue for the public to submit comments and their experience, and they take oral and written evidence and so on. And then they write a report. And one of the interesting questions I think here is the Regan-Udall report, which I on the tobacco side, I'm not too familiar with the food one, but on the tobacco side, not a bad piece of work. But the question is, why was that commissioned by FDA? And a report that came out at the initiative of the commissioner,
Right.
written by a friendly foundation, and nevertheless was still quite scathing, when it should have been the equivalent report, should have been coming from Congress through an oversight process in which the record was, I mean, they've expunged the record, so all the comments that people made have sort of disappeared off their website for some reason, where these things were on the record,
Right.
visible, and people then knew this is how I feed in. So that's my answer to the question about how the citizen does something. Congress has to create the circumstances in which they can do something. Now, James Comer is running oversight on Centre for Tobacco Products at the moment, but it's very hard to see how to really feed into those. It is for me anyway, and I'm a bit of an outsider, but it's not obvious how that's actually going to work. But it is a good sign that they're doing something.
Well, if you can find something connecting his work to Hunter Biden, I think you'll all over it. Can I do political jokes at this gig? I guess not. Okay, go ahead.
So, the congressional question is a good question. I think part of it is that in a lot of healthcare policy for the past 20 years, people have focused on insurance coverage and payment levels. And so things like FDA product regulation or public health regulation through the CDC, those policy muscles have atrophied, if not died and disappeared and vacated. So, I think Congress is working in, reasonably bipartisan fashion, actually, to start to look at these questions. If we look at the Prevent Pandemics Act, which got, rolled into other legislation, it required a Senate confirmation of a CDC director. So that's the first time that will allow oversight. It also required the CDC to write a strategic plan every 4 years, which is sort of funny that you had to be told to write a strategic plan. Think about running a business that way.
Well, in particular, businesses' whole business is planning for a crisis.
Right.
I mean, the only product you make basically is a plan.
Right, and so telling them to have a strategic plan is pretty embarrassing. Plus, they have over, I think, the CDC director has over 15 direct reports, which is not a great way to run an organization. So I think Congress is picking up these threads, having people participate in voicing to their offices what they're upset about, what they're concerned about, and as I said, sort of rejuvenating that public policy conversation around these regulatory agencies and how to make them better and more efficient and more effective, I think is a conversation that we will see more of.
Yeah, please do.
I just going back to CDC, one of the things in Congress, I now hear people now finally beginning to talk about were there costs to a lockdown. So there was clearly a risk of having people contaminate one another with COVID, but there were a lot of costs. And I mean, I looked at this a couple of years ago, just when it started, and people were starting to talk about it, but the CDC never said anything. For example, we have people that weren't getting chronic diseases diagnosed or treated, okay, which caused problem. A lot of depression and anxiety, which I understand is still going on. One of the most interesting ones, and again, I think this is something CDC ought to be looking on, focus, as you put it. Child abuse gets mostly reported by teachers. So if kids aren't going to school and if they're staying home annoying their parents, I'm guessing child abuse must have increased and it wasn't being reported. So all of these things are risks that come out from lockdowns. This is something CDC ought to be good at. They ought to be doing, and yet I haven't seen a word.
I would say substance use and abuse definitely went up during the pandemic. And what happens if you suffer from substance use disorder and you're locked at home for a year, not able to socialize and working remotely and see your friends in your support group? That's not something that was considered. The CDC also engaged in widespread economic regulation through the eviction moratorium, which was struck down. And you say, well, Brian, that's economic impact, that doesn't really matter, or it's a public health question. It's like, well, actually it does. If your livelihood and you're a small business owner and you own a small number of properties and that's where your income comes, and suddenly you're not able to afford your life expenses because you have someone in your property who isn't paying rent and hasn't had to for a year or two, that massively affects your livelihood and also your health.
So does anyone else, we're going to wrap up here. I have one more question that came in from the stream, and it's for Clive. And it's basically kind of a version you asked earlier. What do you do if you don't know what you're going to replace it with? And they applied that question to vaping. They said, is there any concern that vaping is a new enough technology that we don't know the long-term dangers? Do we have enough data to talk about long-term consequences from a new technology?
Yeah, that's a really good question. It comes up a lot. Obviously, we don't have the luxury of time travel, and we can't go forward 50 years and see what happened if people use these products over many decades. However, we don't know nothing either. And you know, when we first discovered the problems of smoking, the science in this area was really in its infancy. We didn't have everything we know about occupational health exposures. We didn't have a well-developed science of toxicology and so on. So now we actually can see what is in the vaping stream today. We can see what goes into the body. We can measure biomarkers, look for toxicants in the blood, the saliva, the urine, and we can kind of project forward how dangerous that will be, you know, as a kind of like a modeling exercise. And what we find is that the exposure to toxicants is very much lower. Most toxicants that you would get with smoking are either not present or are present at very much lower levels, you know, close to background level. The other thing is that the chemistry of these devices is much simpler than a combustion product where like crazy chemical things go on in the burning tip, okay? And that means that the products are much more modifiable. So if something does start to emerge as a problem, you start to find there's a hazardous agent that is forming or there's some kind of metal problem, it's probably fixable before it becomes a big sort of epidemic type problem. So I'm quite confident, really, that the uncertainties will err on the side of moving towards negligible rather than significant new risks. The known unknowns also could mean that we have essentially trivial risk in the longer term, and that if things do emerge, we'll be able to deal with them. And even if we don't, everybody involved would be much better off using these products than they would be smoking. So I think you can take a fairly sanguine view of the long-term prospects without actually having to live through, you know, 6 decades of epidemiology to prove that point.
Dr. Miller and then Dr. Wade.
I would also add, the FDA has over $700 million in user fees related to tobacco products that they collect every year, and has and should have been spending, you know, a significant portion of that looking at long-term health effects.
Right.
And so I suspect that FDA-sponsored research should help us answer some of these questions. You know, I can say personally, my grandfather chain smoked for decades and died of COPD, and my memories of him when I was younger were being hooked up to, after he eventually quit smoking, being hooked up to hundreds of feet of oxygen tubing. So I think in that context, you know, harm reduction and risk reduction is an important space for consumers. And, you know, as I mentioned, over 480,000 people die from tobacco-related illness every year. We should have some urgency for reducing that number and looking at reduced risk products in a thoughtful fashion.
Yeah, I would also add, it's not just how safe vaping products are. Take them away. What will happen? Yeah. Will people go back to cigarettes? Or, and this is a big problem for the DEA, you know, they're creating new drugs now faster than the DEA can get them on the illegal list. So go into some of the rural, I've been in this rural grocery stores, you can buy synthetic weed. All right, some of this stuff we have no idea. Is that where they're going to go, to synthetic weed? Even worse, there are things coming from all over, like from Russia, synthetic opioids. They're extremely dangerous. So it's not just a question of is you know, the vaping less dangerous than cigarettes, which it is. It's take it away. What else will the kids do?
I think that's really important. I mean, the misconceptions about bans and prohibitions, you know, you ban something, it doesn't make it disappear. It just means it's supplied in a different way, in a different form, often worse. You know, people making their own, you think that flavors make vaping attractive to children. You ban flavors, suddenly people are mixing their own, they're buying illicit products. You know, Chinese disposables manufacturers see the opportunity, they flood in. You've got to look at the way the system responds. But a ban is essentially a perturbation of a system. And when you perturb that system, all kinds of weird stuff happens, not what you're expecting or wanting. The unintended consequences dominate the actual consequences, and generally you make things worse than they were before.
Listen, you guys have been absolutely terrific. We really appreciate your time and your information. Dr. Richard Williams, author of Fixing Food, Dr. Brian Miller with the American Enterprise Institute, and Clive Bates, who is unafflicted with doctorness, who has a great website called Counterfactual. I'm Michael Graham with Inside Sources. I'm going to honor them by going out, having a steak, a cigar, and setting my KN95 mask on fire. So that's what I'm going to do. Thank you all very much.
What?
That's